So my recent JASE favorite, why should you know this work? I was asked to identify my favorite manuscript in JASE, and that was not an easy task. That was not an easy task, but I took it seriously, and I decided to search for one. So I started reading a lot of manuscripts that I've seen before, and as you know, well, I'm not going to disclose and give it away right away, so we will have to bear with me for a little while and hopefully get entertained a bit. So as you know, when you submit a manuscript to JASE, you're required to submit a cover letter in which you describe why your manuscript is, why you think that we should publish your manuscript. And I found a few of those that were kind of heartwarming and cute, and I wanted to share them with you before I go into science. So this was one that said that this is a very interesting paper, and we think that the subject is completely new and adds really new information to the subject. So I like that, but I didn't choose this paper to be my pick. This is another one. This one said, further, we believe that this paper will be of interest to the readership of your journal because, and I guess they couldn't find the reason, so they just left it blank. And this one says, it is important to know when cardiac dysfunction starts to initiate treatment for treating or preventing cardiac function. So this was an interesting idea that may be worthwhile pursuing, but this did not become my pick either. This one said, here is the manuscript in English. Or the other one said, there was a name of a reviewer that they opposed to, and the reason for that was that there are no importance in this patients with they had other problems. I guess it's an English
Sounds like I wrote it.
problem, but it was, I like that. This one I read, this is one of my favorites truly. 35, and I enclosed 35 copies of the revised manuscript. And I thought, oh, thank God, there will be no shortage. Dear editor, would like to submit this article to be published in original article section of your ponderous journal. And as you probably noticed, I'm not a native English speaker, so I didn't know the meaning of the word ponderous, and I decided to look it up in the dictionary. And this is what I found. Laborious, weighty, unwieldy, cumbersome, bulky, boring, tiresome, and dull. And I'm still wondering which exactly.
There you have Dr. Perlman there.
Those definitions the authors had in mind, I still haven't figured that out. This one said, two-dimensional strain can detect early left ventricular systolic dysfunction in patients with left ventricular ejection fraction. So this is rather interesting. I thought I would also like to know what happens in patients without left ventricular ejection fraction. And this one is one of my all-time favorites. This is a sentence at the end of a cover letter that says, traditional echocardiography is not far enough. So what is my favorite manuscript? I'll keep the suspense a little bit longer. The answer to this, of course, from the point of view of an editor, the editor's dream is you want to publish papers that you can publish as is so that you don't have to do anything with them, no letters and no comments of reviewers, just say, this is awesome, this needs to be published, publish as is. So how many papers like this do we accept as is of those that are submitted to JASE? I wanted an answer to this, and I looked into statistics in our editorial system, and this is what I found. So 18% we turn down without external review based on in-house review by us editors. We reject 36% after external review with comments from reviewers. We reject and we offer a de novo submission option to 18%. 27% we are willing to reconsider after revisions, and there is 1% that we accept with minor revision, and accept as is 0. So I tried to search my favorite manuscript this way. That did not work either, because there's none of them. They don't exist. However, and this is the winner, For no particular reason, or for a bunch of reasons that I will outline in a second, I chose a manuscript by Dr. Tayal from our friend John Gorson's group in Pittsburgh, and in collaboration with Peter Sagard's group in Copenhagen. And this paper is about mechanical dysynchrony by tissue Doppler cross-correlation is associated with risk for complex ventricular arrhythmias after cardiac resynchronization therapy. This was published at the end of 2015, and I thought it was worthwhile noting, and this is why. So what did these investigators do? This was a prospective study of 151 patients who underwent CRT. Echo imaging was performed before and 6 months after CRT. They used tissue Doppler to derive acceleration curves, which they used to look at ventricular dysynchrony. They divided their patients into 4 groups based on change in contraction heterogeneity. The first 2 groups were those patients who had heterogeneous contraction before and synchrony improved after CRT, and another group that had heterogeneous contraction before and no improvement was noted or worsening after. And the other 2 groups were those who did not have dysynchrony and had no change with CRT, and the last group was the patients who had no dysynchrony, but their synchrony worsened after CRT, which is something that you would not expect to happen. And it was interesting to see whether this does happen indeed, because this is something we do not hear about very often. They looked at outcomes, and outcome events were defined as appropriate anti-tachycardia pacing, shock, or death after 2 years. And what they found was that dysynchrony before CRT was seen in 97 patients, 66%. Dysynchrony after CRT was noted in 39%, so the percent of dysynchrony was reduced by CRT, generally speaking, which is exactly what we would expect and which is the goal of CRT. Patients whose synchrony improved had better outcomes. Again, this is something that we would expect, and this was indeed confirmed in this study. They also found that patients with persistent dysynchrony were at risk of arrhythmias or death. Again, not a big surprise. However, they found that patients who developed new dysynchrony after CRT, and this is something we don't typically think that this is something that can happen. It does happen, and it did happen in 28% of their patients. And these patients turned out to be at higher risk of ventricular arrhythmia or death, which is not good news for CRT, but it is important to know, and this is why I wanted to highlight this manuscript. So what happened to this manuscript after it was submitted to JASE? Well, the first thing that happened, it was reviewers were invited, and then reviewers read the manuscript, wrote their comments, and submitted their recommendations. The editors discussed the reviewers' recommendations and their own opinions about the manuscript after reading it, and the decision was made. And what was the decision the first time around? This is to encourage people to submit, not to get discouraged by rejections. The decision was reject, but the authors were offered a de novo resubmission if they made some important changes in the manuscript that we thought that were crucial for the manuscript to be better and more sound scientifically. Of course, the authors were disappointed. We all get disappointed, but we get rejected, and it's not only in the publication domain. It happens to all of us in life. And these authors, however, were willing to work hard and make an effective revision, which they submitted to us. And this, again, the revision was reviewed, and the decision was made, and the decision this time was accepted with minor changes, and this is how you get to read this manuscript in JASE. Why did I choose this manuscript? I said I promised you that I will explain, and there were several reasons. One of the reasons was that this was a prospective study and well-designed study. It was designed to answer a clinically important question. It clearly stated the hypothesis and the goals of the investigators. The manuscript was well organized and clearly written. They demonstrated the prognostic significance of persisting or newly developed dysynchrony followed CRT, which was interesting. and they emphasized the importance of evaluating dysynchrony after CRT implantation, which was truly a novel concept that we're not accustomed to. And these were the reasons why. So why did I, oh, and one more reason for my choice was that this was not a random study that started and ended and the world forgot about it. The authors continued their work on this topic, and they published a follow-up article in which they found that patients with severe, so they looked into the physiological causes of their findings in the previous paper, and they found that patients with severe LV remodeling with endoscopic volume index over 90 ml per meter square had poor prognosis following CRT device implantation. Another reason why I chose this paper, because it depicts the effectiveness of the review process. And how does it do that? It does it because beyond the flaws that were in the paper, because as I alluded earlier, every paper has flaws, editors saw value and offered the authors very detailed suggestions for improvement. The authors were willing to accept the constructive criticism rather than turn around and submit the paper somewhere else as is without making any changes, and then hear hopefully the same or similar criticisms from editors of another journal. And they were willing to work hard to perform a very effective revision. And the end result was an excellent article that provided new insights into a clinically relevant issue. This is, I think, in my view, this is the goal of the editorial process, of the review, of the peer review process, and I think this paper is one of the examples how it worked well and ended up with what it was supposed to end up. And to finish, I would like to give my thanks, and this time it's not to the audience who is here, although I would like to thank you as well, but the thanks are to Dr. Perelman for relentlessly teaching us the importance of this process without ever cutting corners or compromising the quality of the editorial feedback, which resulted in a bigger picture in the best JASE on earth that I know of.
Victor, fabulous, fabulous. The best JASE on earth. That's fantastic. From the ponderous journal to the best journal. It's spectacular. All right, the next of our featured speakers is our colleague David Adams. And David has the catchy title, which he stole from Victor, called One of My Recent Favorites and Why You Should Know This Work.
Thank you, Randy. And I'm actually here instead of Alan Wagner, who was their first choice. So I'm actually their bridesmaid, their second choice here. But Alan
might be third. He said third.
Third or fourth choice. But he sent me a letter. So I'm actually just mostly going to read this letter from Alan. And so Al Wagner says, I would have liked to be present for this session, but was unable to do so with family visiting. So I asked my longtime friend, me, to stand in for me. So Al Wagner says, my work with JASE began in 2002 when I was asked to serve on the editorial board. By October 2005, I was invited by David Adams, to take over the role of cardiac sonographer education section editor of the journal. When Alan became the editor-in-chief in 2008, he allowed me to continue to serve in that role and then asked me to be an associate editor. I was humbled by that promotion and saw it as an elevation of how important the ASE cardiac sonographer's role was to the journal. Shortly thereafter, Alan asked me to recommend additional sonographers for the editorial board, which I did, and then Alan increased the cardiac sonographers from 3 to 5. Alan also increased the number of JASE articles for CME credit to 10 per year in an approach to help sonographers meet this criteria for maintaining registry requirements. In December 2009, Alan, along with David Adams, Sandy Witt, and Carol Kraft, anyway, wrote a thoughtful editorial comment about advancing recognizing of the responsibilities of cardiac sonographers. This was, I thought, his way of being inclusive, insightful, and thoughtful regarding ASE sonographers. I consistently respected his opinions and actions as editor-in-chief. His letters to authors of the editor's decisions regarding their submitted manuscripts were well written. The inclusion of editorials for some published manuscripts in the journal was another of those changes he made that were very insightful. As my retirement in the field approached in December 2011, I discussed with him that it was time for me to step down as associate editor. He understood, but asked me to remain involved with the editor as a senior consulting editor. Again, I was grateful to continue to serve in this role for JASE. Over the past 5 years, we have remained in communication, and I continue to review manuscripts for the journal. I wish Alan all the best as he approaches retirement, and also to his successor, Dr. Michael Picard, who will be the next editor-in-chief. Sincerely, Alan D. Wagner. So, anyway, when I was asked to stand in for Alan, I guess the third or fourth person, I thought I had to come up with my own article that I thought was, groundbreaking or something like that. And I also came up with some of the editorial comments that we see throughout the journal, usually in response to some other article. And this editorial comment about the advancing recognition of the responsibilities of cardiac sonographers was really in a response to this article at the same journal about the advanced cardiac sonographer. And it was sort of a response that Dr. Perlman, asked Carol and Sandy and I to sort of come in on him with as a response to this new credential and the role that advanced cardiac sonographers might or might not have in a laboratory. And I thought that was just brilliant because, and I've told people this before, I wasn't a real fan or a proponent of having another credential, number one, or the role of an advanced cardiac sonographer. There were some people in our society that was really pushing it, and so I thought it was just brilliant that we would come up with this editorial comment that just gave sort of a different viewpoint. And to me, that was one of the strengths that Dr. Perlman always brought to the journal, was that, he could accept other people's viewpoints, but he also had his own strong viewpoints. Now, I've known Dr. Perlman for 35 plus years. I remember as a young sonographer coming to the lab in Seattle, and he had this sort of crazy 3D system with spark, transducers up in the ceiling, and I remember sitting there with his senior sonographer, Carolyn Jenko, and almost falling asleep because I would watch her, pulse and CW every valve, 2 or 3 times in every view. I mean, it wasn't what we did at Duke, but he was always very good to me. And I just sort of remember that, my mom would always say, Mother Adams would say, I want to meet your friends, because she said, I know more about you by who you hang out with. And so I'm sure she would have been very proud to have met Dr. Perlman. She never did, but because I learned so much from him. And I think every time I would see a review that I had submitted and see his responses and his corresponding reviews and his letters to the editor, it always made me a better person to critically think about the papers, and then also to help my sonographers not make the same mistakes that I saw in other manuscripts and even my own submissions. So thank you, Dr. Perlman. And again, Alan Wagner is super sorry that he's not here to say these words himself. So thank you.
So Dr. Perlman has some remarks.
David, thank you for, hang on just a second.
Sit down, Jonathan.
Thank you for standing in for Alan, and I thought it was probably appropriate, since we have a couple minutes, to make an editorial comment. I wish there were more David Adamses and more Alan Wagners in the world. When I started in Seattle in 1978, I had one tired old ATL ultrasound machine that did M-mode and pulse Doppler, and probably nobody in the world used something like that. I had two very skilled sonographers, Terry Dooley and Don Franklin, and I run into Don on rare occasion these days, and they were doing Doppler studies on everybody and their grandmother. They'd never seen a 2D echo, and I had some background in that, so it was a nice marriage. But I remember sitting in audiences in meetings where people would say, people who I've respected for forever, that sonographers certainly couldn't possibly do Doppler exams because that involves hemodynamics, and a physician has to do that to be able to understand it. Well, it was pretty clear to me that the two sonographers that had taught me understood things pretty well, and they were bright folks, and it was pretty clear to me that there really weren't a lot of limitations in terms of what sonographers could do. I've always thought that echo was a team sport, and that when played correctly, the sonographers and the physicians learn from each other. I am afraid, at least my observation has been, that over time, and with the big push on throughput, that the amount of interaction that occurs is much less than it has or was in the old days, and I wish there were a way to incorporate that. So I simply want to follow up on David's comments and to say, for any sonographers in the audience who want to model their lives after Alan or David, and take science seriously, and take education seriously, and not worry about whether you get on the 5 o'clock bus or whether your studies get uploaded to the server, even if you didn't get to put in all of the data. We would love to have more help from folks like you. I don't know that I should, but I think I probably can speak for Dr. Picard and say that I suspect he shares many of the same perspectives. So thank you for letting me give that little editorial. And now, Dr. Lindner, you can head this way. Jonathan and I have known each other for a long time, since my youngest daughter babysat for his now not very young daughter for a number of years, and he's been one of a group of wonderful associate editors. And he's here to speak about an interesting topic titled, one of my recent JASE favorites, Why You Should Know This Work. Jonathan Lindner from Portland.
I wish I could say that that was the first time and maybe even the last time that I had to sit down and listen to Alan. So there are really very few positions in our society that require...
Are you going to activate different slides?
Oh, yeah, absolutely. How do I...
Thank you, Dr. Picard. Dr. Picard was taking his editorial role seriously and telling me to advance the slides.
There we go.
Great.
Yeah, there are very few positions in our society that actually require more effort, more time than the editor-in-chief of JASE. The exec committee takes a lot of time, but it's concentrated over a very short period of time. The editor-in-chief, over about 10 years, has required so much time, so much effort from Alan. And when Jeff and I were talking, I don't know, about a half a year ago about what this session was going to look like, it was less about our favorite articles and much more about conveying to you the editorial process, and more importantly, what Alan has done to essentially promote an aura of excellence about JASE. And that's what my talk is going to be mostly focused about. So in terms of longevity, let's just think about how long Alan has been the editor-in-chief of this journal. So the iPhone had just been released when Alan was put into this role. Barack Obama announced his candidacy for what was then considered the most respectable position in the U.S. The first issue of JASE that year had articles on the novel idea of imaging LV twists, so a concept that's now essentially part of our persona. And the impact factor for JASE was 2.06, which has more than doubled since then, and I think people will be very happy with what happens later this month when the new impact factor probably comes out. So what I would like to do is to kind of talk a little bit about what Alan said in the early years of his editorship and how he has followed through on those to essentially bring excellence to the journal. So I'm going to give you a bunch of quotes and show you how things have followed up. So number one, meeting the needs of our readers. In this editor's page, Alan said that JASE is committed to publishing novel and clinically relevant articles that will help our readers take better care of their patients, yet readers also want us to identify those new techniques that not yet have clinical relevance. So those two concepts, so novel and clinically relevant, those are two thresholds that Alan always wanted to bring forward as the very first threshold for an article to essentially get through. So I'm going to do something unconventional here, and I'm going to show you a couple of articles. I'll start with one article that Alan would have never published. So, and I'll show you why, which is this is one that is novel, but hopefully not clinically relevant. So Alan would have never, who came to the Edler lecture today? So you heard about neural networks. Well, this is avian networks for diagnosis rather than neural networks. So this was a study that was published to see whether or not pigeons could be trained as observers of pathology on chest x-rays and mammograms. I think that I'm trying to think of the justification for this, and I think it's that you can actually find pigeons at night and on the weekends. No slight on my radiologist in the audience there. So here are the results, the soaring results that are indicating that the interpreters were not just winging it. So number one, if you actually looked, these pigeons could be trained to be actually quite accurate in terms of their interpretation of chest x-rays and mammograms, and they could actually be trained earlier if you actually gave them magnified images. Now, interestingly, if you gave them magnified images, they did not have any advantage to actually having rotational images, so they weren't any more accurate. And I think that actually has the fact that they actually had problems manipulating the mouse and the control. Yeah, no fingers, no ability to control. Now here's the interesting thing, which is, and this is the thankful part from the radiologist, which is the bottom graph shows that the pigeons actually could not train each other. So they could not essentially pass this on from one bird to another. So that essentially, there was a sigh of relief coming from the radiology audience, I'm sure, that there wasn't going to be a major coup. Sorry. So here are a couple of other articles of questionable relevance, which would never appear in JASE under Alan's stewardship. Number one, here's Egg in Your Eye, a prospective study of blunt ocular trauma resulting from thrown eggs. Wax on, wax off, I'll let you read that one. Children and mini magnets and almost fatal attraction. And factitious diarrhea, a case of watery deception. So none of these interesting titles, but clinical relevance very questionable. So would have never met that threshold from Alan. Now here is a study that actually did meet a threshold, and it didn't not only met the threshold of novel and clinically relevant, but it was important enough that the editorial team, and especially Alan, thought this needed to come out and come out quickly. So this is not what I consider incredibly high science, but important science, which is around the time that this article came out, everybody was realizing that all of the different strain systems, both online and offline strain systems, were giving slightly different results. And so this was a large study, essentially just comparing global longitudinal strain in the same patients and seeing how it varied from system to system. So people know about this now, people talk about this now. This had immediate impact because everybody was realizing that they were getting slightly different values from different systems, and if you were going to be using this for longitudinally following patients, for example in cardio-oncology, that you would need to do it with the same system and that you'd have to be mindful about these things. So an example of novel, clinically relevant, and essentially the level of excellence that Alan always stood for. Here's the next quote from Alan. This actually was pulled from two of his editor's page. Feedback from reviewers should be timely, courteous, and constructive. We have an obligation to accuracy and honesty. And if one cannot trust the results of a scientific inquiry, then nobody is served. So scientific excellence. Who here has published in JASE? Raise your hand. Now leave up your hand if you've ever had a paper published in JASE where the editorial comments were longer than either of the reviewers' comments. Yeah, everybody. So Alan essentially created an atmosphere where we were beholden to not just what the reviewers wrote, but all editors had to review every single paper and provide input. And nobody provided more input than Alan. And Alan not only provided input on the usual things in terms of scientific quality and whether or not the graphics were accurate, but did everything. I mean, paid attention to every single detail. Here are just some of the things that I don't often see in other editorial reviews. Number one, making sure that the title is reflective of the study and not embellished. Making sure that the description of the study design is accurate and complete. Alan set up a process for expert statistical review that is in place, and anybody who's had a statistical review as part of their papers know that these are really very accomplished statisticians that aren't making you do cartwheels and machine-based learning, but are actually people who are providing real excellence to the paper. Importantly, making sure the conclusions do not overstate what the results show, and making sure that a novel hypothesis or idea is being tested. So once again, here's an article that was just recently published, and I put this in as one of my favorites. It is a paper on the importance of VA coupling in end-stage renal disease. So ventricular arterial coupling is essentially the relationship between arterial elastance, which is the stroke volume and systolic pressure relationship, and end-systolic elastance, which is left ventricular and systolic volume or diameter pressure relationship. And it's essentially a way of looking at whether or not the ventricle is actually maladapting to load, in a sentence. And in the study, it was end-stage renal disease patients, and they looked at long-term outcomes of patients according to all of the traditional things that sometimes we think about, like EF, some of the measurements of left atrial pressures. Here's just arterial elastance alone, here's strain. And then here's the relationship between arterial elastance and end-systolic elastance, which is essentially VA coupling, and showing the divergent outcomes in these patients. And it wasn't just good enough that we showed that it actually had prediction. This study actually went and looked at the global chi-squared. And the global chi-squared is essentially a way of saying, how incremental does this add to our clinical information or the other information that's standard? And you can see that in these two situations, the natural log of the VA coupling actually was very additive to some of the easier or standard things that we think about that are determining mortality and morbidity in these patients. So why is this paper, why did I think it was important and reflective of JASE? Number one, just like Victor just showed you, I think that there are certain things that this paper really kind of reflects about the journal. Number one, it was an international study. There is no disadvantage of being an international submitter to JASE, and Alan has made sure that that happens. It was a large study with a pretty long follow-up for this cohort. ECHO was used to evaluate complex information on cardiac and vascular interaction, so not just cardiac, but actually thinking about the whole system. There were advanced statistical methods. Clinical impact was demonstrated by showing incremental value, and it emphasized opportunities for improving outcomes through modulating load. So a very important study, I thought. Now, here are a couple studies that probably could have benefited from Alan's input, from a JASE style of very active editorial input. So these are titles that probably would have been changed by Alan if they came through. A rose is a rose is a rose, but what exactly is gastric adenocarcinoma? My favorite, Crazy Like a Fox, Validity and Ethics of Animal Models of Human Psychiatric Disease. Head and neck injury risks in heavy metal. Headbanger stuck between rock and a hard base. A lucky catch, fishhook injury of the tongue. And that last one down there, which they probably could have benefited for the non-interstellar geologists, they're just calling it the eighth planet. Finally, why featured research was a topic that Alan brought up. So readers of JASE are not very interested in esoteric research articles with little practical use. Yet, by providing a full menu of offerings, our readers will have the best opportunity to stay current with our always exciting and ever-changing field and to anticipate future developments. So, one of the things that Alan always held for us as the editors is it is okay to accept kind of more basic or edgy science as long as it would be interesting to our readership and it would eventually lead to something that was meaningful. So here is one of my favorites, which is not a recent article, but from 2008. And this is from Meryl Shara Crosby. Mike, I think you may have been an author on this as well. And the title of this was Echocardiography on Translational Research of Mice and Men. Back then, it wasn't necessarily conventional that we would publish studies on murine echocardiography. I mean, who was interested in murine? Well, I'm interested in murine echocardiography, but very few other people are. Now, Alan essentially said, no, this is our technology is not just for clinical diagnostics. It's for, and I remember these conversations. It is a research tool, and it's a research tool not only in people, but it is scalable. And because of that, Alan was very much in favor of this article becoming part of our published manuscripts, and it has really served as really a benchmark in serving for industry and basic scientists to use echocardiography for evaluating systolic function. And there have been many follow-up articles of looking at murine strain and things like that have followed up from this, but this is really one of the first to kind of set the stage for creating guideline documents, if you would, for mirroring echocardiography. And then one last one, which I'm going to mention, which was from this last article. And the reason why I put this one in is it's from my lab group. And JASE has always been kind, the stuff that I do with molecular imaging and some of the perfusion imaging and therapeutic ultrasound, kind of basic science stuff. JASE has always been extremely good to me about essentially saying, yeah, this is something that actually has a future. It has something that is moving in a certain direction. And this was a study where we have developed a way of doing, I won't go into it in detail, but it's essentially a way of doing a very rapid rest-stress perfusion imaging of the limbs for a diagnosis of peripheral arterial disease. Bottom line is we use stress test imaging all the time in cardiovascular disease and for the heart. We never use this in the limbs. We rely on ABIs and PVRs. And this is essentially a study looking at stress rest perfusion imaging of the limbs, which takes about a minute to do. So I'm going to finish up with this slide, which, when we meet every 2 weeks as the editors, we circulate a listserv about all the articles, and everybody kind of chimes in. And on that listserv, Alan always puts some of the most pithy comments. And those comments are not only insightful, they're sometimes humorous, and they sometimes have lessons from life in them. So let me just go through some of these and tell you what I learned from some of these pearls from Perlman. Number one, it seems to me that someone who works near a radiation source is more likely to get exposed to more radiation than someone farther away.
Brilliant.
Second one, the authors believe, probably correctly, that getting the wrong answer repeatedly is not as good as getting the right answer repeatedly. So essentially, those two comments essentially teach me that when you're writing articles and when you're presenting science, don't state the obvious. It's not needed. Just go directly into what's new, what's important, and what's challenging. Next, one cannot predict deaths retrospectively since they have already happened. Next one, I'm not sure what borderline right heart disease is. This sounds a little like borderline pregnant. So those two comments essentially taught me that you need to be precise in your language and triple check your work. Finally, I was amused, especially by naked fever, apparently usually followed by, dude, she is hot. So these are actual comments from Alan. From that last one, sense of humor. So it's amazing how a mundane task of every 2 weeks going through all of these articles and discussing their merit, discussing their limitations, if you keep your sense of humor about you, it can be a much more enjoyable process, and you keep those around you who have to do the process with you engaged and very appreciative. I'll finish up by thanking Alan for all of his insights. He was a mentor to me, still is a mentor to me in life and in science and everything that I do. I'd also like to thank all of the associate editors that I've worked with. Many of them are here in the audience. It's just been an absolutely wonderful time to actually learn from each and every one of you. And Debbie Meyer, who's sitting in the back, who has worked so hard for the journal as well. Thank you.
First of all, for those that don't know this journal, because the first issue was in February, is the new journal from the American Society of Echo. It's currently being published only electronically. There is not a paper version of this every 2 months. It's open access in the sense that you can retrieve the information and download all the images and videos. And also has a different structure. I have a co-editor, that is Karen Zimmerman, which also works extremely hard to get this thing off the ground. So you guys have interesting cases because it's a relatively new journal. I only have an example of a very unusual submission in this case. You can see the subject was nothing to do with cardiology, but with UIN. And I think the impression that the people had is that you could submit any type of case, and actually they submit all the pictures and all the information. And we have to tell them that, sorry, this is a journal that is dedicated, at least for the moment, only to cardiovascular diseases, and hopefully the word has spread and we haven't had any other weird cases reported. But obviously you have to be in the alert when you get this type of request. I have to admit that I didn't feel that I was an expert in that particular field either, so we have to reject that. Again, because it's relatively new, I'm going to show very briefly also the nature of the cases that are short and condensed. And I'm going to show 3 cases that is to give you a flavor of the type of cases that has been submitted and we have published. The first one is the first article of the first issue by Lucy Safi from my Picard's laboratory. And this case that we chose as the leading article is about a female that had an incidental finding of a cardiac mass during workup for weight loss. I'm choosing this case because one of the new thing that was new for us, the editors and the reviewers, is that all the cases a lot of those cases have been submitted, not only echo, but all these cases, or many of these cases, also have other modalities, and is becoming a new standard. So this case, obviously, you can see the finding wasn't subtle. Also look that we were able to show high-quality videos, and I think this is fundamental to the practice and analysis of echocardiography. And we're still working very hard to try to have this process very smooth. You can see in this particular example the quality is good enough to be downloaded and presented as a PowerPoint presentation, showing very well the obstruction of the mass to the RVOT. And again, as many of these cases, this one in particular came accompanied from multimodality. This is an example of the CT scan that was submitted, showing very clearly the mass. It wasn't because we couldn't see an echo, but this confirms obviously the presence and the extension of the mass. But also for tissue characterization, the authors show also submitted the MRI images, again, to help with the diagnosis and confirm the present extension of the mass. And this case was biopsy proven that was a high-grade spindle cell sarcoma. So what brings us also to the editors is now that we're picking reviewers, we cannot only rely in expert echocardiography. We have to expand or to focus the reviewers also in familiarity or expertise in multimodality imaging. The second one also express our profession has expanded not only usual diagnostic techniques, but also expanded into the cath lab and the OR for helping procedures. This is, I had to underline that because we also have a few cases of this age. This is a 91-year-old patient with severe aortic stenosis and underwent successful percutaneous aortic valve replacement, but a few months later he comes back with heart failure, and this is published in the second issue of the 2 that we have published our journal. Also show the sophistication of some of the submissions, again, because we are focusing on the videos, and these authors actually had a very nice production. They have subtitles. The arrows are theirs too, and a high quality TEE. And you can see, for the ones that are not familiar, that you can stop and pause and get all the information that these authors, with great care and work, were able to produce. Again, as the prior one, I also emphasize that, and it's typical of percutaneous aortic valve replacement, that this patient usually have multimodality. And again, you have to be familiar at least with the basic views and the structure that are portrayed on CT scan. And this one was to corroborate, again, was very obvious on the echocardiogram, but I can at least you see better the struts or the stent of the prosthetic valve and the relationship between the other structures. This case also had catheterization for percutaneous closure, and of course, in this case also intraprocedural echocardiogram showing the technique of percutaneous closure of that device and the success on this particular case. Again, emphasizing the fact that you have to know the procedure, you have to know the images, and you have to be familiar with one more modality. And finally, the third case, this is also highlight the international nature as in the prior case. This is a case submitted and accepted from Australia. And this is a 59-year-old woman with shortness of breath and heart failure. And part of the workup concluded that she had multiple multiple myeloma and amyloidosis. And this patient was submitted to a very aggressive chemotherapy regimen, and finally peripheral blood stem cell transplantation. And the core of the case is summarized. There were other images and other videos, but I think they summarized very well the nature of this case. You can see here on the top changes in the myocardial structure of the LV after treatment, and a relatively classic apical sparing of the strain, and how it improves over time, something that probably, at least I wasn't familiar, and it's probably not the rule, but maybe the exception, that some of these cases that can be treated effectively with chemotherapy also can reflect improvement and in the LV function, and the global strain went from -8 to -19, that is considered normal. So again, an important case in terms of, it was unusual, they have a good follow-up, and you can, again, quickly learn from these cases looking at a single images. Now, just to finalize, and obviously my talk is shorter because it's a brand new journal, but we have learned a few things. First of all, given the level of submission that we have still getting, it proved that there is good demand for a case-based journal, and I'm glad that the ASC made a decision to go on board on this and produce this journal. I think there are high educational value in most of these cases, and we're trying to present the one that has the most value out of the submission. Important again, the multimodality cases are now the norm. Half of them has CT scans, a third has MRI, and 1 in 4 has 3D images, some of them TE images. So again, and I'm sure that not for this journal, for many journals, the main obstacle that we have or still having is the review process. It's difficult to get reviewers on board. It's difficult to get the responses back. I think if you submit a case, you would like to have the response tomorrow because there's no statistical analysis. There is not really much of the methodology, and it's still keep with that. We need to get the response faster. And again, we need to expand the pool of reviewers. Now we can send them complex MRI images and complex CT images in order to have a fair review and complete review process. I think this is my last slide. And I also want to thank Dr. Perlman. I learned quite a bit from you when I was a reviewer, and you go by your comments. Sometimes you put me to shame because my review looks a little bit superficial after your comments, but for me personally it was a great opportunity to learn from you, and thank you very much.